Hi everyone, my name is Dr. Jagdish Chaturvedi, your friendly neighborhood ENT teacher, and I hope your FMG exams went well. I'm sure ENT में आपने अच्छा किया होगा because if you had attended my rapid revision, as I told and as I promised, more than 90% of questions have come from that rapid revision. Though I agree that it has not come directly, but those same concepts have been tested by your examiners just in different ways. तो अगर आप थोड़ा सा मेंटल एप्लीकेशन और कॉमन सेंस लगाएंगे then it is basically the same stuff and I'll show you. But of course there has been a question or two that are not covered in that. वो हमेशा होता है, some bouncer questions आते हैं, that's why 90% to 95% come from the rapid revisions, just like told. So let's go through these questions very quickly. This is straightforward. Patient presents with stridor, so cannot breathe. Stridor, so can patient is in stridor and cannot be intubated. So what is the appropriate next step? See, these questions have been just a recall, so it may not be exactly framed. I'm not even putting options because most of the time people are saying, "Sir, ये option था नहीं, ये option नहीं था," because that is not the point. The point is the topic of stridor, and if you cannot intubate, what is the next option? So if you have the option of tracheostomy, then that would be the correct option. But I don't think tracheostomy was there as an option. So if there was anything else like cricothyroidotomy, one of these two, then that would be the correct answer. If there is no intubation, then you can't even do laryngeal mask airway, you can't do bronchoscopy, you can't do anything else. You can either do tracheostomy or you can do cricothyroidotomy, which is basically finding alternate airway from the neck. So if any one of these options is there, even percutaneous tracheostomy, then that would be the answer. Though I have a feeling, listening to a lot of students, that cricothyroidotomy was one of the options, so that would be the correct answer in this case. Very straightforward. Tympanometry, impedance tympanometry is showing that there is a sharp peak at 0 dpa, which is over here. That means there is no negative or positive, it is right in the midline. And with high compliance, what is the most likely diagnosis? So see, this is compliance, ye wala graph, this is the compliance graph, typically measured in mmHOS, which is also called as Siemens. It is the measure of inductance, measure of compliance. Okay, and here there is another one, static admittance, which is also in centimeter cube. So these are two ways to measure the same thing. If the compliance is very high, then it would point to an AD curve. D means deep, depth, which is also seen where there is ossicular discontinuity. Suppose if there is very less compliance and it is stiff, then that would be AS. S meaning stiff or small, which is not giving much compliance. So here, if the question is saying high compliance, then the answer would be AD. If the question was saying low compliance, I don't know what exactly it was because different students are telling different things. So if it is showing low compliance, then आप समझ लो answer is AS. So that is very clear. Tympanometry और impedance audiometry बहुत बार पूछा जा चुका है. ये वाला question तो कितनी बार directly आ चुका है. Diabetic male with facial pain and blackish discoloration. So diabetes is the clue. Blackish discoloration during COVID, mucormycosis was always there, and bony erosion is also seen. So anything that is sounding like mucor or fungal, invasive fungal rhinosinusitis, any of these words would be there. That would be the answer. It is not sinusitis, it's not allergic rhinosinusitis, it is not that. It is going to be something that is pointing to mucormycosis or invasive fungal disease. वो option है, that would be the correct answer. Now, male patient presents with high frequency hearing loss, that worsens in noisy environment. What is the most likely diagnosis? Also asked many times there in our rapid revision, guys. The only condition where hearing worsens in noisy environment is sensory neural hearing loss. And if they're saying high frequency hearing loss, that means they're talking about a sloping hearing loss in the higher frequencies. तो अगर हाई फ्रीक्वेंसी हियरिंग लॉस है, सेंसरी न्यूरल, एनीथिंग दैट इज पॉइंटिंग टू हाई फ्रीक्वेंसी सेंसरी न्यूरल हियरिंग लॉस वुड बी द करेक्ट आंसर. इट कैन नॉट बी कंडक्टिव हियरिंग लॉस. तो ओटोमाइकोसिस तो नहीं है, सॉरी ओटोस्क्लीरोसिस, तो स्क्लीरोसिस नहीं है. ओके, ओटोस्क्लीरोसिस में उल्टा होता है. Otosclerosis mein there is a condition called paracusis villi in which noisy environment the person can hear better because of masking effect and also because people talk louder in noisy environments. It cannot be Meniere's because Meniere's mein kya hoga? Meniere's is low frequency hearing loss. It is upward slope, not a downward slope. It is more in the lower frequency, so that nahi ho sakta, though it is sensory neural hearing loss. Acoustic neuroma also the sensory neural hearing loss is not sloping high frequency variety. There will be sensory neural hearing loss, but it will not be of the high frequency. High frequency is typically seen with aging. So your correct answer would be anything related to presbyacusis, or even if there is something like ototoxicity or noise induced hearing loss, kuch bhi agar option hai, yeah, presbyacusis, which is age related, the most common, that would be the correct answer to pick over here. Now, patient presents with history of fall and there is bleeding from ear. What is the investigation of choice? Such a basic question. So many times it has been asked. High resolution temporal scan, CT scan of the temporal bone. HRCT, temporal bone plane. Not contrast. Contrast is when we are expecting some glomus tumor or some vascular structure. Otherwise, a plain high resolution CT scan of the temporal bone is the investigation of choice for any ear assessment, because temporal bone houses the inner ear and we need to see the ear. The temporal bone HRCT is going to be the investigation of choice. Fairly very basic. Tip of the uncinate process typically attached to which of the following structures? A basic anatomical question, though it is not exactly explained, but this is one of the surgical steps of FES which has been covered. Now here you have to use a little bit of logic. See, inside our nasal cavity, make the nasal cavity like this, we have a superior turbinate, we have a middle turbinate, and we have an inferior turbinate. Now this uncinate process, it starts from the inferior turbinate, but it can basically attach to three different areas. It can attach to this, which is a lamina peparissia. It can attach to the middle turbinate, or it can attach to the skull base. Any of the three areas it can. The most commonly attached tip is attached most commonly in the lamina peparissia, which is the medial border of the orbit or lateral border of the nasal cavity. So the lamina peparissia would be the most common answer if that option is there. If that option is not there, then middle turbinate or skull base, any of them would be the answers of choice. Cannot be inferior turbinate, the tip has to be up, so it definitely cannot be below it. It cannot be bulla or cannot be any other structure. Bulla ethmoidalis, concha bullosa, it cannot be any of those. Concha bulla ethmoidalis and uncinate के बीच में ही hiatus semilunaris and infundibulum होता है, so it cannot attach to that structure. So this is also straightforward common sense and anatomical understanding. Patient presents with enophthalmos, means eye is gone inside. Exophthalmos, eye has come outside. So enophthalmos and periorbital ecchymosis after being hit by a ball based blunt injury is always going to be a blowout fracture. Floor of the orbit ka fracture, and is very straightforward, also covered in our rapid revision. Here again, these are covered in our rapid revision and theory, but little bit thoda sa application use karna padega. The image below shows lateral view of face with highlighted region in front of the ear. So this is the front of the ear is the area which has been highlighted, which is along the zygomatic arch. So it is zygomatic abscess. This you don't, even if you don't read, you can just use your logic and you can answer this. Post auricular will be behind. Results is along the sternocleidomastoid muscle. Results along sternocleidomastoid. If it is along the posterior belly of digastric, if it is along the posterior belly of digastric, then that is Sittelis abscess. If it is in the temporal, under the temporalis muscle, then that is called Luke's abscess. So answer of exclusion also very, very straightforward. This is the digastric one. Sorry, this is zygomatic one. Now, a professional singer, difficulty in raising pitch of her voice after thyroid surgery. So basically, there is low tense or tone. There is only one tensor, which is cricothyroid. It is an adductor and tensor. It shortens the space between the cricoid and the thyroid. So when it contracts, because it's an external muscle, it lengthens it. It lengthens it by increasing the tone. So this is the only intrinsic muscle that is lying externally, and it is also the only intrinsic muscle that is supplied by the external laryngeal nerve or external branch of superior laryngeal nerve. So if you have external laryngeal nerve or external branch of superior laryngeal nerve, this is supplying the cricothyroid. This is a very, very straightforward answer. Many times the same thing the examiners have asked Tod Madodke, and in future also they don't have any fun in asking you in the exact same way. So think about what is the clinical application that they are asking, and that is how this answer is going to be. Human papilloma virus is most strongly associated with which of the following head and neck cancers? Very, very simple, guys. Human papilloma virus is associated with all orifices. You think of any orifices. So oral cavity, rectum, vagina. Right? So in head and neck, the only cavity that is relevant for head and neck is oral cavity. So if any oral cancer is the answer. Any other carcinoma will most likely, suppose if you look at nasopharyngeal carcinoma, that is by Epstein-Barr virus. All right, and laryngeal carcinomas or hypopharyngeal carcinomas, those are usually because of cigarette smoking or toxin, not really because of this. Human papilloma virus can cause recurrent laryngeal papillomatosis, which if they don't say a tumor, they say head and neck cancer. So that would be a kind of a papilloma is a kind of a tumor. So human recurrent laryngeal papillomatosis is something that is caused or associated with HPV, but not laryngeal cancer. All right. Now, what surgery is being performed in the image below? You can see that this is a total maxillectomy. Total maxillectomy. Everything is removed. There's this incision being made. The entire maxilla has been removed. So you can see that this is in the area of the maxillary sinus. So either facial degloving or maxillectomy would be, and it is total, not partial. There is no ethmoidal, sphenoidal, or any other thing that is there in this particular area. The straightforward common sense you can see in the image. Narrowest part of adult laryngeal airway also has been asked many times. Usually they ask it with rima glottidis. Rima glottidis is the space that is there between the true vocal cords. And this is usually the narrowest part in adults. In children, the narrowest part is the subglottis. That's why they have a chance of getting subglottic stenosis. But rima glottidis or true vocal cords, or if there is no other option, just the vocal cords would be the right answer. They can even also say thyroarytenoid muscle. Different ways of asking the same thing. The space between the thyroarytenoid muscle, space between true vocal cords or rima glottidis all mean the same thing. Okay. A patient presents with a fish bone stuck in the piriform sinus or food pouch. During removal, accidental nerve injury, here they are trying to ask you about the internal branch of superior laryngeal nerve, the one that supplies sensory supply. Instead of asking what supplies the sensory part of the larynx, inner larynx, instead of saying internal branch, they try to make a clinical case because everything is application based nowadays. They're asking fishbone is stuck in piriform sinus. During removal of the procedure, which nerve is injured? Internal branch of superior laryngeal nerve. And finally, a patient presents with lung injury and tympanic membrane rupture following exposure, which could be a bomb exposure. Which of the following is a blast wave effect? So when there is a bomb explosion, following an explosion, not exposure there. So following an explosion, because a lot of bombs, wars are happening. This is a question that we have not usually covered, and this falls in the 10% that is not covered. But also, this is commonsensical. There are usually one, two, three, and four levels of injuries, and these are also categorized in different ways as primary, secondary, tertiary, and quaternary. Primary is because of the bomb fumes that are going inside any of our airway cavities, lungs, nose, ear, eustachian tube, all of that. Any body cavity injury is a primary injury of a bomb explosion. That would be the correct answer in this stage. Secondary is because of any blunt or penetrating injury coming directly from the bomb. So that is, the bomb has exploded and those things have come inside our body and they have caused secondary injury. Tertiary injury is because of the impact, the motion. You've fallen down and you've hurt. So that is because of the impact and motion. And the fourth is burns, the burns and the heat and the fire. So the answer over here would be grade 1 or primary, whatever the options that were there. We don't know what exact options were there, but our job is to tell you what the answers are regardless. So don't worry about what options were there, not there, but this is what your answer is and what would be closest based on this. So with that, guys, thank you. I think ENT was very straightforward, and there is not anything outside of ENT that can be asked except for these one or two questions. So do follow the rapid revision and the theory sessions. Otherwise, ENT is fairly straightforward. हाँ, थोड़ा common sense, application, and clinical understanding you have to do. Otherwise, it's the same things being asked again and again. All the best, guys. Take care.